All right. Well, first off, thank you all for taking the time to come on here. Well, let me just adjust one setting real quick. So just a little bit about me. I'm Max Crystal. I'm the clinical director at Sana. I've been with Sana coming up on 2 years. Prior to joining Sana, I worked in community mental health as well as in hospice care. So I practice in a variety of settings. One of the main reasons that I joined Sana was when I worked in hospice, I saw the end of substance use. I saw a lot of clients who were dying in their 50s, 60s as a direct result of the chronic medical conditions that happen with substance use. And I wanted to learn a lot more about it. And when I came to Sana, it really opened my eyes to see the ability to intervene a lot earlier throughout that process. I'm also a licensed independent clinical social worker in the state of Vermont. And we'll get started. So today's presentation isn't just about diagnosing substance use. It's understanding the why beneath the behavior. Our lens will integrate attachment theory, developmental psychology, and trauma-informed care to examine substance use through a relational context. We're going to be defining substance use disorders, going over some clinical understanding. What is a substance use disorder? What qualifies someone to have a substance use disorder? We're going to be looking at some DSM criteria. We'll then identify common symptoms of a substance use disorder and see how this presents in day-to-day life, behaviorally, emotionally, physically, and socially. And importantly, we really want to frame the symptoms of a substance use disorder as adaptations rather than a dysfunction. We'll talk about prevalence of substance use disorders and the co-occurring mental health conditions that often come with it. And we'll work to normalize the experience to reduce stigma, to connect it to broader and systemic relational patterns. We'll then move into attachment theory. We'll do some foundational work regarding Bowlby and Ainsworth and how attachment theory came to be. We'll then move in to explore the relationship between attachment and substance use. Lastly, we're going to look at some treatment implications and see how attachment styles and early attachment experiences can affect clients' way of interacting with clinicians and the world around them. We're going to use a case example. This is a client that I worked with when I was a hospice social worker. And we'll be applying theory to analyze this from a clinical lens. Lastly, we're going to talk about cultural dimensions and how that affects substance use disorder treatment. And then we'll have some questions at the end. My hope is that everyone's going to leave this presentation with a richer, more compassionate framework for understanding our client substance use in the lens of their early experiences. So when we talk about substance use disorders, we'll first start with what substances people use. And it's important to note that substance use is not limited to illicit drugs. It spans legal and prescribed medications. It also can include behaviors that stimulate the neurochemical pathways. So we have alcohol, which is the most widely used and socially accepted substance. Caffeine and nicotine are often overlooked, but can be highly habit-forming. Cannabis is increasingly legalized, yet still has dependency potential. Stimulants like cocaine and methamphetamines, opiates, including heroin, fentanyl, and prescription pills like Oxycontin. Sedatives such as benzodiazepines, Xanax and Ativan, hallucinogens and inhalants. Behavioral addictions, lastly, regarding gambling, sex, food, and increasingly digital technology. Importantly, all of these substances and behaviors hijack the brain's reward circuitry, particularly the dopamine system, creating a cycle of cravings, pleasure, and withdrawal. and what starts as voluntary use can often become compulsive. Many individuals are using these to help them regulate emotions. Substances, while many individuals use them, it becomes less about the euphoria, but more about relief from anxiety, depression, trauma symptoms, and emotional numbness. Importantly, substances serve as a regulatory or compensatory role, especially in the absence of secure attachment and effective coping skills. When we think about substance uses, instead of asking a client what is wrong with them, we can ask them, what need is this substance meeting? When we view substance use through this lens, it opens the door to a trauma-informed, attachment-based approach. When we start to look at the actual criteria for a substance use disorder taken out of the DSM, we think about how a substance use disorder is a problematic pattern of use that causes clinically significant impairment or distress in a person's life. It's often less connected to the frequency of use, but it's more about the consequences and loss of control. The core criteria of a substance use disorder are using more than intended over a longer period of time than planned, unsuccessful attempts to cut down or stop. A great deal of time is spent in obtaining, using, or recovering from substance use. The presence of cravings is often an indicator for strong urges to use. Continued use despite social, interpersonal, legal, and health consequences. Clients will often find themselves in dangerous situations, such as driving. The presence of tolerance to substance use, needing more of the substance to get the same effect, and the withdrawal symptoms that come along when a client is not using. Based on the number of criteria that these clients are experiencing, they will then be put into a continuum from mild to severe within the DSM. Why does this really matter? Is because recognizing a substance use disorder can help frame substance use as a medical and psychological condition, not as a moral failing. Clients will often experience shame, and being able to name their experience within a diagnostic framework can reduce self-blame and promote engagement in care. There is a relational function of these symptoms, and many of these criteria reflect disruptions in relationships, roles, and routines, the very things that are tied to secure attachment. For example, the use despite interpersonal conflict or job loss may reflect an impaired ability to seek connection, regulate distress, or to feel safe without substances. So when we're meeting with clients, some of the things that we may see when diagnosing substance use disorder is there's a multidimensional impact. Substance use disorders often manifest across physical, behavioral, emotional, and social domains. These symptoms are often misinterpreted as personality flaws, laziness, or oppositionality, when they may actually be indicators of dysregulation. Some behavioral symptoms can be poor attendance or performance at school or work. This might be due to withdrawal, exhaustion, or the lifestyle. Secretiveness, lying, or stealing often reflect shame or the compulsive need to maintain access to a substance. Legal problems or risky behavior, such as driving under the influence or altercations, are often connected to the impaired impulse control or judgment impair. Psychological or emotional symptoms such as mood swings, irritability, and anxiety may stem from withdrawal or the motivation or the emotional dysregulation that is often present with a substance use disorder. A loss of motivation or an inability to feel pleasure is often caused by the changes in the brain's reward circuitry. Fearfulness, paranoia, and isolation can result from stimulant use, trauma, or chronic substance use related anxiety. There may be physical changes in sleep, weight, or appetite, including tremors, slurred speech, red eyes, or poor hygiene. This often reflects the deprioritization of self-care as the substance takes over daily function. There can be relational and social indicators, such as changes in friends or hangouts. This can signal a shift towards people who also use substances. Financial problems often occur as substances are expensive and maintaining a habit may be overriding other responsibilities. When we view these symptoms through a trauma-informed attachment lens, we may ask, what might these behaviors be protecting them from? And how are these signs of a nervous system in distress or survival mode? Prevalence. 1 in 7 Americans ages 12 and older reports experiencing a substance use disorder. Importantly, substance use disorders do not discriminate. They affect people of all race, gender, socioeconomic status, and regions. Importantly, substance use disorders are chronic, however, they are treatable, classified in a similar condition as diabetes or hypertension. This is not a phase or a character flaw. It's a condition that needs to be managed with appropriate care and support. While there is no single cause of substance use disorder, it's often thought to be a convergence of genetic, environmental, psychological, and relational problems. For many people, substance use disorders can be a response to unprocessed trauma, mental health systems, attachment injuries, or systemic stressors. Sustained use of substances alters the brain, reducing natural dopamine production, impairing impulse control, and increasing sensitivity to stress cues. These changes also fuel cravings and increase the risk of relapse. It's really important to understand the shame and stigma that can happen with substance use disorders. There's still a widespread view in our society among many people that having a substance use disorder is some sort of a moral failing. This view prevents people from seeking treatment. Families also carry shame, which can lead to silence, blaming, or enabling. As clinicians, we can work to reduce shame and reinforce the idea that recovery is possible and that this disorder is treatable. We can help people by normalizing this experience, realizing that they're not broken, they've adapted to painful experiences. And we can highlight that treatment is not just about abstinence, it's about rebuilding relationships, trust, and emotional regulation. Co-occurring disorders. A co-occurring disorder refers to when a person has both a mental health disorder and a substance use disorder. It can also be referred as dual diagnosis. And rather than being the exception, this is the norm. 25% of adults with serious mental illness will also present with a substance use disorder. Many common co-occurring diagnoses are depression, anxiety, PTSD, psychotic disorders, and personality disorders. This is not a full list, however, oftentimes can be co-occurring. This list is often not coincidental, as both mental health and addiction often are rooted in similar shared root causes, such as chronic stress and dysregulated attachment. These conditions also share overlapping risk factors, including family history and genetics, childhood trauma, emotional dysregulation and impaired executive functioning, and neurochemical imbalances. Individuals with co-occurring disorders can often experience treatment challenges as symptoms can mask each other. For example, depression may be worsened by substance use withdrawal. Anxiety may improve when using substances, complicating diagnosis and treatment. Mania or psychosis may be triggered or mimicked by stimulant use. Individuals with dual diagnosis may have poor engagement in care, higher relapse risk, and greater stigma, even from mental health and substance use providers. This is why integrated care is so essential, because treating one condition without treating the other is often ineffective. Mental health symptoms can be a barrier to sobriety, and untreated substance use can interfere with psychiatric recovery. To provide integrated care means you need a team that has a similar treatment philosophy, a treatment plan, and a trauma-informed, attachment-aware, person-centered perspective. We can do this as clinicians by realizing that clients with co-occurring disorders are not difficult, they're just carrying more pain. Our therapeutic relationship with the client becomes ever more important. And stability in treatment can often offer new models for both emotional and behavioral regulations. Attachment theory. Attachment theory was originally developed by John Bowlby, who was a British psychiatrist and psychoanalyst trained in Freudian psychoanalysis and child development. He worked with what was considered emotionally disturbed children in London during and after World War II. He developed attachment theory while working for the World Health Organization in the 1950s, after observing the emotional and social effects of separated children from their parents. He emphasized that attachment bonds are biologically programmed and essential for survival, not just emotional, but rooted in the evolutionary need for protection and regulation. He rejected the Freudian idea that attachment was just about feeding. Instead, he proposed that proximity to caregivers is a biological need. He introduced the idea of internal working models, which are mental blueprints about the self and others are formed through early caregiving experiences. His work was expanded upon by Mary Ainsworth, who was one of Bowlby's students. She brought attachment theory into the empirical and evidence-based research world through direct observation. She famously developed the strange situation experiment in the 1970s through structured observation of infants' reaction to separation and reunification with their caregivers. She identified three main attachment styles based on this study. The first being a secure attachment style. This is when if a child is distressed when a caregiver leaves the room, but is able to be easily comforted upon return. For those of you who aren't familiar with the strange situation experiment, it was when the caregiver would be essentially, they would leave the room and then you would study the infant's reaction to both the leaving and the reintroduction. The anxious or ambivalent attachment style for a child, this is when a child was clingy, highly distressed, and not easily soothed when the caregiver returns. For an avoidant attachment style, this is when a child shows little distress and avoids the caregiver upon return. Later researchers added a fourth category, characterized as disorganized attachment styles, which is seen in children who display contradictory freezing behaviors, often due to trauma and abuse. This matters because these attachment patterns set the foundation for how an individual regulates emotion, relates to others, and responds to stress throughout their life. Early caregiving shapes whether people learn that the world is safe or reliable, or dangerous and rejecting. Attachment theory bridges developmental psychology, neurobiology, and relational psychotherapy. It helps clinicians understand why some clients seek closeness and others withdraw even in crisis. It's particularly relevant to substance use disorders, as many clients use substances to self-soothe in the absence of secure relational templates that would be established in early life. A secure attachment style is it's developed when caregivers are consistently responsive, emotionally available, and attuned to the child's needs. The child experiences co-regulation with their caregiver, as well as safety and validation. This leads to the internal working model of I am worthy of care and others can be trusted. As an adult, these clients are often comfortable with emotional intimacy and independence. They're able to regulate emotions and ask for help appropriately, and they have low levels of attachment anxiety or avoidance. From a neurobiological lens, connections between the prefrontal cortex and the limbic systems, an effective modulation of their stress response. In the context of substance use, individuals with a secure attachment style are less likely to develop substance use disorders. And if they are, they're more likely to seek help, trust providers, and engage in recovery. They often tend to benefit from traditional therapeutic approaches. An anxious attachment style originates from inconsistent caregiving, when caregivers are sometimes loving and present, sometimes distracted or unavailable. The child becomes hypervigilant and preoccupied with staying connected to the caregiver. The internal working model that develops is I must work hard to be loved and others may leave me. As an adult, these clients often crave closeness, but it is felt as insecure or needy. They often fear abandonment and seek frequent reassurance, and they may over-identify with relationships and struggle with boundaries. From a neurobiological perspective, these clients have a heightened amygdala reaction activation or a fight or flight response. They have a less developed prefrontal cortex, which impairs their ability to self-soothe. In the context of substances, these clients may use substances to self-soothe or cope with relationship instability. They're likely to experience intense emotional distress in early recovery, and they may have a hard time tolerating therapeutic boundaries. An avoidant attachment style originated with caregivers that are emotionally distant, rejecting, or discourage emotional expression. The child learns to suppress emotions to avoid rejection or punishment. This creates an internal working model of I can only rely on myself as others will let me down. As an adult, these clients value independence and self-sufficiency. They may struggle to access or express emotions. They may dismiss closeness or minimize relational needs. From a neurobiological lens, they have reduced activation in social emotional brain networks. There's a disconnection between emotional experience and conscious awareness. And in the context of substance use, they may deny distress or minimize substance use. They're less likely to seek help or stay in therapy. They may have a resistance to group work or emotionally focused modalities, and they may use substances privately as a hidden coping mechanism. Disorganized attachment styles are often created by caregivers that are frightening, abusive, or highly unpredictable. The child experiences caregiver both as a source of comfort and a source of threat. This resolves in a confused, chaotic internal response to connection. This creates an internal working model of the world is dangerous and I don't know how to stay safe even with people that I love. As an adult, they may experience extreme emotional reactivity, disassociation, or identity confusion. They may repeat cycles of trauma in relationships. They have a high risk of personality disorders, self-harm, or suicidality. From a neurobiological lens, they have a chronic hyperactivation of the amygdala. They have fragmented or underdeveloped integration between cortisol and the other regions of their brain. They may also carry a high load from the wear and tear of chronic stress. In the context of substance use, there's a strong correlation with early trauma, complex post-traumatic stress disorder, and high-risk substance use. Substances can often serve to regulate overwhelming or contradictory inner states. They may have a difficult time trusting any caregiver or provider, and they have a high dropout risk in treatment. These internal working models are very durable. They are unconscious beliefs that we form in early childhood about ourselves and others. They can act as an emotional blueprint. A child that is exposed to neglect, inconsistency, or abuse may internalize that they're not worthy of being cared for, or people will hurt and abandon me. These, without intervention, will persist across the lifespan. They can affect romantic relationships, friendships, parenting style, self-help and therapy engagement. Working models are relatively stable, however, they are not fixed. Positive relationships, secure attachments in adulthood, and therapeutic alliances can help to reshape them. However, in the absence of these relationships, individuals can repeat the same patterns. Many individuals with insecure or disorganized attachment styles struggle with trusting us as treatment providers, following treatment plans, or staying in group settings. Their internal working models tell them people don't understand me, or it's dangerous to let other people in. Substances can then become a replacement for attachment, as substances are predictable and controllable in a way that human relationships are not. Attachment shapes brain development. Early relational experiences directly impact how a child's brain wires itself. Secure attachment supports the development of brain areas responsible for emotional regulation, memory, and executive functioning. Insecure or disorganized attachment is associated with a chronic stress response, which can interfere with the growth and integration of these brain areas. The stress response system is going to be affected by an attachment style. In securely attached children, the high road of processing is engaged during stress, whereas in an insecurely attached child, the amygdala, or the low road, becomes hyperactive, meaning that the brain is constantly on alert, interpreting neutral events as threats. Over time, the impact of this high cortisol levels can cause wear and tear on the body, increasing vulnerability to physical illness, anxiety, depression, and critically, substance use as a coping mechanism. When a secure attachment is absent, individuals may turn to substances to stimulate the dopamine system, feelings of safety, pleasure, and relief, which addiction hijacks. As a therapist, trauma-informed treatment must consider that these neurobiological adaptations. Healing is not just physiological, not just psychological. It involves rewiring how the brain responds to stress, connections, and care. Internal working models are essential when we think about how attachment styles work later in life. As I said, these are unconscious templates formed through early experiences. They can answer key emotional questions such as, am I worthy of love? Can I rely on others? And is the world predictable or dangerous? These models guide how individuals interpret others' behavior, regulate emotions, and navigate relationships. They influence attachment behaviors, trust, boundary settings, emotional vulnerability, and even self-worth. For example, someone with an avoidant model might believe needing others is weak, while someone with an anxious model might believe if I don't stay close, they will leave me. Working models shape brain circuits, especially in the prefrontal cortex, which governs self-awareness, empathy, and interpersonal predictions. Insecure working models often correlate with increased amygdala reactivity and decreased prefrontal cortex regulation under stress. These models drive relational templates in friendships, relationships, and professional interactions. Importantly, they affect help seeking. Clients may assume that a clinician will reject, misunderstand, or abandon them, regardless of the clinician's behavior. These models can be changed through consistent, safe, and attuned relationships, especially in therapy. Clients with an insecure attachment style can develop security. Therapy helps them to update their internal working models to reflect new relational experiences that challenge past beliefs. As we know, attachment does not disappear in adulthood. The need for connection, attunement, and emotional regulation continues throughout life. When secure relationships are unavailable for safety, individuals often seek alternative methods that meet the same need. Through this lens, substance use can be seen as a surrogate attachment. Drugs and alcohol can mimic the soothing and numbing function of a secure caregiver. For someone who never internalized co-regulation, substances can feel like the only way to modulate intense emotional symptoms or chronic emptiness. Attachment theory deepens the self-medication hypothesis by also realizing that substances may replace an unmet need for security, predictability, and comfort. Many individuals with insecure or disorganized attachment struggle to form healthy bonds. When they experience intense interpersonal failure, rejection, or emotions, they may turn to substances. The shame, isolation, and relationship damage that result further entrench their internal working model of unworthiness and deepen substance dependence. The same neural pathways that are involved in bonding, dopamine, and endorphins, are activated by addictive systems. Substance use hijacks the attachment system and creates a false sense of safety and reward. This is especially prominent in those with trauma histories where the brain is already primed to seek quick external soothing. Recovery can involve helping clients recognize what emotions or relational needs that substance use was meeting. By building secure, trusting relationships in treatment, this can allow for the rewiring of the attachment and reward system. Clients don't just need to stop using. They need to replace substances with an authentic human connection that feels safe and consistent. This is a client that I'm going to call Walter, who I worked with in my work. My work as a hospice social worker, and it shows the effect of insecure attachment on the lifespan. So Walter's a white male in his late 60s. He was physically and sexually abused as a child. He has a long-standing pattern of un, unstable employment, incarceration, and multiple substance use disorders, including alcohol, opiate, and tobacco. As a hospice patient, he was receiving care for advanced COPD, but his behavior made him ineligible for some supportive services as he was verbally abusive to the staff, would misuse narcotics provided for his care. He was socially isolated, distrustful, and emotionally reactive. Walter's life trajectory offers a clear but tragic illustration of what happens when early attachment trauma goes untreated. He's not non-compliant. He's someone who never learned how to feel safe in relationships. His early attachment wounds are blocking him from accessing the very care he needs. We can see that Walter likely has a disorganized attachment style due to abuse by the caregivers who are meant to protect him. He operated under the internal working model that the world is not safe and people can't be trusted. He then brought that internal working model into the end of his life with his caregivers. He shows how signs of emotional dysregulation, poor distress tolerance, and inability to form safe connections. As a result, he relied on substances to regulate his system, to manage panic, numb, and assert control. The early trauma likely affected his brain's ability to regulate arousal and stress response. Chronic amygdala activation and underdevelopment of executive functioning resulted in impulsivity, reactivity, and a distorted threat perception. Walter's criminal history and drug use aren't just moral or legal issues. They were an attempt for him to survive with the tools that he had. Walter did pass away on hospice services. As a result of insecure attachment patterns, chronic illness, and estrangement, this all led to Walter's early death. His case shows attachment wounds as lifelong illnesses and the impacts that can happen from early childhood trauma if it's not addressed. Unfortunately, Walter never received treatment for his substance use disorder or trauma. When we start to think of how we treat clients, we can think of treatment as a relationship. Clients with insecure attachment, especially avoidant or disorganized, often struggle with therapeutic relationship. They may distrust clinicians, test boundaries, or push away support. Avoidant clients may downplay distress, intellectualize, or seem high functioning, but can be emotionally flat. Disorganized clients tend to alternate between clinging and pushing away. Clients may be difficult to diagnose clearly because of complexity and intensity. As clinicians, we can use mindfulness and somatic practices to help these clients build tolerance for distress and access higher level brain functioning. Psychoeducation regarding attachment can increase insight and self-compassion. And a consistent, non-judgmental presence from the clinician helps to remodel the internal working models over time. We can view substance use as an attachment substitute. Treatment must explore what need is the substance meeting. Only once we can discover that can we help clients develop alternative ways of finding safety, connection, and regulation. As a therapist, we may be the first earned secure attachment in a client's life. This relational repair is core to recovery. It's important when we think about attachment styles and as clinicians being aware of the attachment styles of our clients to realize that attachment theory is universal, but its expression varies. Attachment theory was developed in the context of Western culture. All human beings are wired for safety and connection. but how that connection is expressed depends heavily on cultural norms and community structures. Some examples of different attachment patterns: in Tanzania and Nigeria, caregiving is often distributed across multiple adults. In East Asian cultures, emotional restraint may be seen as respectful rather than detached. These practices do not create insecure attachments. They reflect different relational rhythms. The Western bias of attachment theories means that clinicians must be cautious not to pathologize caregiving differences that do not align with these models. Research findings show that in cross-cultural studies that secure attachment can be achieved through all of the caregiving arrangements we've shown above. It's not about who provides care, but upon emotional attunement. As a clinician, we can practice cultural humility by asking instead of assuming, view family structures through the client's lens, and reflect on our own cultural biases as a provider. Secure attachment is not about following one script. It's about meeting the universal need for emotional safety, however that may look. Want to open the floor to questions, and thank you all for listening. This is a topic that means a lot to me, and it has been my pleasure to share. So thank you.
All right, thank you, Max. I've got a couple questions for you, and I'm going to start them off. During this question time, if you have anything that pops into your head that you want answers for while we're going over questions, feel free to keep submitting them, and we'll get to them as we can. But I'm going to start with the questions of what modes of treatment have been proven effective with clients in this area of need. So, kind of what modalities maybe.
Yeah, I mean, off the top of my head, I would have to go back to the research a little bit. Um, there's really a variety of attachment or a variety of therapies. The most important thing that I think of is on one of the slides we talked about the somatic experiences that people have and using those the ability of sorry, I'm trying to collect my thoughts here. um, using all using many different modalities to establish that safety and connection within the body. I think that you could use your more traditional DBT, CBT, ACT. All of those have plenty of efficacy in this, and you could also go for the more somatic attunement-based therapies.
Great, great. Okay, we'll move on to the next question I have. How can you help the client develop healthy attachment as part of their recovery plan?
Yeah, I think when I think of recovery, healthy attachment in recovery, we can think about the idea of what do you use to create a secure base. And I think that this is why communities of recovery are so important. Thinking about how recovery and isolation can be very challenging. I think when you look at the idea of a 12-step community, for instance, you have a group of people, there's an established safety within the group. There are sponsors, people who are literally insulated in the community to create those secure attachment relationships that you may not have. So I think that outside of, for instance, like an inpatient treatment setting, you could help clients find a community. I think, like it talks about in here, the relationship with an individual therapist can be so meaningful as well, given that that may be like the first instance of a secure attachment that clients can have.
I love that. Next question is, do personality disorders play a role in substance abuse?
Short answer, yes. I think all co-occurring mental health diagnoses have to be taken into account, especially personality disorders. I do think that it can be very easy to diagnose a personality disorder in someone with disrupted attachment patterns and substance use put together. It's one of my main cautions to the clinicians at Sana, for instance, because we have detox and residential levels of care. So most clients are coming in detoxing, and um, I really discourage uh, these kind of like aggressive diagnoses of personality disorders early in recovery because of all the insecure attachment patterns that may be playing out that can present like different personality disorders. I think particularly a high prevalence of borderline personality disorder diagnoses, which we know is very connected to early childhood abuse and neglect, which can also really just play a big factor in how we conceptualize a client. Because I think it's very easily to conceptualize a lot of these behaviors through a personality disorder instead of through an attachment lens.
Totally. Okay, this next question is from Kimberly, and she asks, do you tell your client about their attachment style and history and explore that with them? Or do you just take note of this approach while working with the client?
I think for me, it depends on the client and the level of insight they have. For instance, the example of the client that I gave, Walter, he was a client with very little insight into into most things. When with clients that have greater insight, I think it's certainly appropriate, but I would kind of defer to the therapist on what they believe to be helpful. I think, here at Sana, for instance, one of our clinicians runs a group looking at different attachment patterns, and clients find that very helpful in realizing, like, oh man, maybe some of this behavior that I'm experiencing is not like a character flaw. It's a response to this experience I had earlier in my life. So I think that if the clinician found it like beneficial to provide that psychoeducation to clients, it can help illuminate patterns. However, I don't think it's a hard and fast rule, just like with anything that it would depend on the client, the therapist, and the situation.
All right, we've got a question from Alan, and he asks, how do we better treat substance abuse in our increasingly aging population?
Yeah. I think that's a really good question. And this was one of the challenges. It was what brought me one of the biggest challenges that brought me to Sana, like I said, was watching people at the end of life with really chronic substance use disorders and where that leads. And being able to hopefully disrupt that cycle earlier is so helpful. That being said, I mean, I was just talking to a client like right before this, probably an hour ago, who is like in his 70s. It's his first time at treatment. And he was just telling me like what a cool experience is. He's like, I've never tried to stop drinking before. Um, I think that opening up our treatment centers to clients of a variety of ages can be so helpful. It does certainly present with challenges, especially clients with physical health conditions when they're older. I also think that as clinicians, we need to check our bias a little bit because I know that I've certainly heard the thing of like, oh, is it worth getting sober when you're, that old or something like that? And I think that it can be I think that ageism can be a really big factor in how we as clinicians conceptualize older clients with substance use and being aware of that bias. And it's often an unintentional bias, right? Most of us aren't going to say, think of this as a negative thing, but it may just be this internal bias. I think being aware of that bias towards older adults can be really meaningful.
All right, this one's a little bit of a longer one. So if I need to repeat this, please let me know. But this question says, I'm interested in the clinical application of attachment theory to some of the challenges we see in recovery. Specifically, how might an individual's insecure attachment style, particularly avoidant or disorganized attachment, manifest as a barrier to engaging with and connecting to the mutual support model of 12-step programs. For instance, how does the emphasis on surrendering to a higher power and building fellowship interact with a deep-seated mistrust of others or fear of dependency?
Really good question. I think, um, let me just go back to my slides a little bit. I think that
Yeah.
it's when you start to look at internal working models, right? Like if with someone like a really insecure attachment style, or really disorganized, of this idea like the world's not safe, people can't be trusted. It creates this, it can create a really big barrier towards trusting a group of people. Um, I see this in treatment a lot of just, and I'll talk a little bit about 12 step in a bit, but I also want to talk about just the impact of disorganized attachment on group work in particular can make it so that clients do not want to be a part of the group. They will really be resistant to anything that involves other people. They'll like, because it has this internal working model of no one will be able to meet my needs. Like I can't trust this group of people to meet my needs. I can't trust you as my therapist to meet my needs. That is probably the biggest barrier that I see. And I think one of the beautiful examples that 12 step inpatient treatment settings can provide anywhere where there's a safe, contained group of people is that it is that corrective attachment experience. Like clients will experience, what does it feel like to be in a group of people and feel safe? They'll start to feel that co-regulation and that attunement, which is so hard. It's also so meaningful to have that corrective experience. I think that 12 step groups, I guess I haven't thought too much about the higher power aspect when attachment. That's a really interesting topic that I'm sure there's a ton of research about. I've more thought of it through the lens of other people. You know, can I trust my sponsor? Can I trust my therapist? Can I trust these people? And looking at it as a barrier, I do think it's so important to realize that like when you frame things like this, to me, when I first started learning about this, it was like, oh man, disorganized attachment styles, it's like it's not like you're doomed. Like the ability to these models can change over time with corrective experiences. So I think that being a part of a group, a part of a group of people is the most powerful example of a corrective attachment experience. And I think that as clinicians, we have the most we just have this beautiful opportunity of interacting with people in a way that's like I'm going to show up every day at the same time. You can get mad at me, that's okay, I'm still going to come back, right? I can model appropriate boundaries, I can model what it's like to sit with you while you cry, I can model what it's like to talk to other people. Like we have this opportunity to offer these really beautiful attachment healing experiences for people, which can hopefully change those internal working models.
I love that. That was a great answer. It's a great question. Okay, next question we have is: do you feel the reward theory of addiction and the attachment theory in the development of addiction are comparable?
Can you say that one more time?
Yeah. Do you feel like the reward theory of addiction and the attachment theory in development of addiction are comparable?
I'm not sure I entirely understand the question, and I know the person can explain it a little bit more, so I'm going to take a stab at it. Um, I think when I think of when I think of a secure attachment, they have that secure base that provides this almost like reward pathway in the brain. My caregiver's attuned to me. It helps me self-regulate. I then feel okay. The absence of that, people will sometimes turn to substances to meet the same need. So in that sense, I do think that substances and a secure attachment, like almost like a secure attachment, or sorry, a substance can almost replace a secure attachment. We know that it doesn't actually, in the long run, work, but in the short term, it can really fill that void that can be left by an insecure or disorganized attachment. I believe that's the question. If I didn't hit it, really sorry. Email Allie. I'm happy to talk to you more about
Yeah, and you
it.
can put it in the chat maybe if we have some time, if you want to clear up if that didn't answer the question, feel free to resubmit it.
Totally.
Oh, they said it answered their question, so that's great.
Oh, that's nice. Thank you.
Okay, maybe just a couple more questions. This person says, how can I move forward and treat my clients with a more holistic viewpoint?
It's a good question. I mean, I think it probably depends on the practice setting. I think that um, in a private practice setting, for example, one of the things that is extremely powerful is if clients have this insecure attachment style of the world is not safe, it's interesting to see what is safe and to help them to have some corrective experiences in the world. I know, for instance, some private practice therapists that will kind of like take therapy out of the office a little bit to like nature. We do a lot of ecotherapy here of like the clinicians call them walk and talks, where we have some hiking trails around. So they'll do like therapy while just walking. I think the idea of like integrating the body and the mind in any way you can, even that if it's just through simple walking, can be super powerful. There are other like, kind of specialized trainings regarding somatic experiencing that can be quite powerful. I did when I was actually we have a clinician down in Nashville who does the Cali Connect therapy.
Mhm,
Pretty
mhm.
cool. I did it. I'm a believer in it. I didn't know beforehand, but um you can do, attach or trauma informed yoga classes can be really powerful. So even if we're not a client, or even if you're not like a clinician in that, you can encourage your client to access different modalities. That's like for me, right? Like I come from a very traditional clinical background. I'm not trained in yoga or, Cali Connect, right? But I can oftentimes, do my individual therapy with people and then also connect them to other resources. And I think that using that lens of I'm going to address some psychological, and then we're also going to do things to address the impact of trauma on the body, where all of this is stored is pretty cool.
Yeah. Cali Connection is a really cool therapy. If you get the chance to look it up, she's got a great website that kind of explains what she does. But we got two more questions, and then we'll let you go for the day. But this next one is from Gretchen, and she says, "Is the medical model of SUD obsolete these days with the newer theories relating to attachment and so forth?" And she specifies, she said, "This is not my area of specialty, so."
It's an interesting question. I work very closely with our medical team here, and our medical providers are amazing. And I think we need medical providers. And I think that we need medical providers that understand this lens. I think that us as, this medical model of pathologizing addiction, labeling clients as, disruptive, non-compliant is the big one. Oh, they're non-compliant in their medication, right? They're non-compliant in this. And, I think like that example of Walter, right? He is the core example to me of a non-compliant client that through a medical model of care will be absolutely thrown away like he was, right? He was pushed into prisons, pushed into institutions because of his inability to accept help, his inability to be respectful with caregivers. So I think that the medical model is evolving a lot. And I think there's still room to grow. Like there's room for all of us to grow. Um, but I'm a huge fan of interdisciplinary collaboration to treating addiction and attachment style. Like there's no way to do it without it. So I think that working with a team of great psychiatrists, medical providers, nurses. There's amazing providers out there that have taken the more traditional model of medical education and really adapted it to a trauma informed lens that takes into account all of the things that we've discussed.
We got another kind of longer question, but again, if I need to break this down for you, let me know. But this one says, when we discuss risk factors for substance use disorders, we often list things like genetics, environment, peer groups, and co-occurring mental health issues like anxiety, depression. How does an attachment lens change our understanding of this? And then they say, should we view insecure attachment not just as another risk factor on the list, but as a foundational one that can amplify or even activate other biological and social risks?
It's a really good question. I don't know. I think if I had an answer to that, I'm not sure. I think, uh, I guess the way that I view it is that just like with any other risk factor, attachment style does not indicate substance use. I do think that being aware of our clients' attachment patterns can give us a unique lens into their help seeking behaviors. It can give us a unique lens into what treatment modalities may land and be effective. It can give us a lens into how we work with clients in a way that both respects their internal working models and provides corrective experiences. So for me, I view when I think of attachment style, I think of it a little bit less as a risk factor and more of a way to say, hey, like I'm, based on my biopsychosocial, this client, like all the, it seems pretty likely and through my interactions with them that they're kind of falling into this disorganized pattern with me. Can I be aware of that pattern as a clinician and can I work with them to provide that corrective experience? I think that's how I would address it.
Okay, we're going to end with this question. I think this is a great question to end with. But Brooke asked, do you have any specific resources or books that you would recommend if we were interested in diving deeper into this topic of attachment styles and addictions?
Ooh, that's a really good question. Um, hmm. If you want the biggest book on attachment theory, like if you're like, Max, give me everything. Wait a sec. There's this book that um, attachment. It is like the Bible of attachment theory. Um, it's extremely helpful. There's a ton of resources in there. Um, I think that would be kind of like, I mean, it's an extremely clinical book. Like you're not going to read it for fun, but if you're like really into the research, evidence-based stuff, I would go for that. It's called The Handbook of Attachment Theory, Theory, Research, and Clinical Applications by Jude Cassidy and Philip Shaver. Um, Super great resource. I was pointed to it a number of years ago, and it's been extremely useful and effective for me.
That sounds great. Yeah, someone just put, and I will do this. I'll find a link to that book, and if you think of any other resources or books after this webinar, I'll include it in the post email to folks who have joined.
What I'll also do, Allie, is if you
Uh-huh.
want to include I didn't the references slide to
Oh
this,
yeah,
that has this book and many other ones. And so yeah, I think that references slide, if you want to send that out to people, is that has pretty much everything.
will do. Yes, everyone will receive a copy of the PowerPoint. That should be the last slide on the PowerPoint. But okay, that was all the questions. We're going to wrap up here. I'm just going to remind you guys again. As soon as you close this webinar, there should be a page that pops up with the CE evaluation. Please fill that out, and then we'll kind of go from there. Um, if you don't, for some reason, see the link to the survey, I will also be sending that out in an email by the end of the day. Any other questions, please feel free to reach out to those emails that were listed earlier. And we can answer those. Thank you guys for joining us and taking the time out of your day to be with us and to learn about this subject matter. And we hope you have a great rest of your day.
Thanks.